Good afternoon, everyone. We are delighted to have Professor Maria TASSIGNON from Antwerp with us today. She's going to give her keynote speaker right in the beginning before we start. And the keynote speaker and the keynote is on anterior vitreous detachment and how it influences our cataract surgery. Something extraordinary and out of the way. Maria is an excellent speaker, an excellent surgeon, and I'm sure we'll enjoy her talk. Please.
Thank you very much, Keki. And I'm so happy and so honored to be here. And I would like specifically to thank Keki Mehta, who I know for many, many years. And I went several times to Bombay. It was almost my second hometown. And also operated there, life surgery, etc. It was a little bit stressful, but a very nice experience. And based on all those people who invited me and who believed in my new approach, I have now evolved also in my knowledge about what is behind the lens. And it's not a black box. There is really something that we have to think about and that we have to know. So it doesn't go forward here. Can you do it? Yeah. So these are my disclosures. I have intellectual properties in the back in the lens ring caliper, but also in laser technology, limbal niche replacement. The Berger space is a space that is, in fact, described in 1887 already. It is it is described, but just in one page, in one book, and that's all. And it was described by Berger, who is from Austria. But the most important person is not Berger, is in fact Uyghur. Because Uyghur, he described that little membrane, and I don't know whether I can show you that little membrane where the anterior hyaloid is attached, close to the posterior capsule. And that is in fact, that little membrane is in fact, the Uyghur ligament is in fact the ligament that defines the Berger space between posterior capsule, anterior hyaloid, and that ligament of Uyghur, plays an enormous role in our accommodation. If it becomes loose, you lose your accommodation as well. It's not the only factor that plays a role in accommodation, but it adds to accommodation as well. Now, one of my mentors was Jan Worst. Keki Mehta knew him as well, and quite a lot of people must have known him. He was a wonderful person from the Netherlands, our neighbors from Belgium above us. He was a wonderful person. I learned in his lab where the Berger space is, and that white space that you see in the middle, that is the Berger space. And it's then that I said, okay, that space is big enough in order to accommodate a lens. But I have to pay attention that I have not to make the lens too big, because it must be accommodated in a space between 8 and 9 millimeter in width. So that's the reason why I made the back of the lens 7.5 total width. So here you have it again, Uyghur ligament, attachment of the anterior hyaloid to the posterior capsule, and that is such an important ligament. That ligament is so tight that it doesn't allow cells to pass through it. So it is also a meshwork. It's a meshwork that prevents cells to go behind our lens. For example, in cases of uveitis, you will not have cells entrapped there unless you have a detachment. If you have a detachment of the Uyghur ligament, then you may have cells there. So now, how do we know that retrolenticular space of the Berger space? What is the best to say? Berger, you can use that space when you have still an attached ligament. Otherwise, it's better to use the retrolenticular space. To fill it, look very carefully here. You see the border of the cushion that is formed when injecting viscoelastic, and that is the limitation. That's the attachment of the ligament of Uyghur. So, in fact, you can see it during surgery. If you look very carefully, then you can already observe that ligament clinically. You don't need very much sophisticated devices. But of course, it's easy for me to say that. I learned about the space of Berger by using the OCT. And the first time I had the OCT, embedded in the microscope, in the Zeiss microscope, was in 2015. And then I could, for the first time, convince the people and the audience, look, indeed, we have both capsules of the anterior and posterior capsule that are entrapped in the sulcus of the lens. And you don't need to have much more evidence to that. You glide both blades, the anterior posterior one, in the lens groove, and then you will have, little by little, you will have the lens really positioned, completely stable. And maybe those of the ophthalmologists who prefer most to use it are the vitreoretinal surgeons, because the visual axis remains clear, no adhesions of the iris to the capsule back at all. I have good news, is that Aravind will make that lens very shortly for India, and then I hope that I will also be able to coach the people who wants to use it here. So now the person who first defined an AVD in clinic is Emmanuel Rosen, also a very well-known person from the UK who had who developed so many new things. And in fact, the AVD, when you look at this, at the drawing at the right side, for your ease, I colored the anterior capsule in blue, the posterior capsule in red, and the anterior hyaloid in green. And you see that the green and the red never touch each other. So that means that if you have that without inflating that space, that means that you have a spontaneous detachment of your anterior hyaloid. And then we did, of course, a study to see patients older than 60 years, or in fact starting from 45 years. Well, we found out that the AVD is an aging process. Just like we have a PVD in the posterior segment of the eye, we have an AVD. I do not know yet whether AVD and PVD are linked to each other, whether it is a mechanism that is combined or not, or there is a difference in timing that I do not know yet, but it is quite interesting also to learn about that. Now here you see a patient who has a very dirty visual axis, and when you look only in the clinic, you do not know where those dusts are located. And when you do the OCT, you can see it. It is in the Berger space partially. Why? Because you have an AVD. The anterior hyaloid is loosened from the posterior capsule, so cells can float from the ciliary body, can go in that space. Also, of course, in the anterior vitreous, and that is, of course, not very important to know, but that means that the patient will have always a dirty vision, a blurred vision if you don't take it away with vitrectomy. Now, how do you recognize whether you have an AVD? You don't necessarily need an OCT. When you have, for example, this is a pseudoexfoliation syndrome, when you have a capsule, posterior capsule, that is really floppy and easily snapped in your irrigation aspiration probe, that means that you have a floppy capsule. That's an AVD. That capsule is not supported anymore by the anterior hyaloid. So you know it just by looking carefully when you do your operation. And this is also the reason why young people in the beginning, they have tears of the posterior capsule, because they don't think about that that the capsule may sometimes not be very well supported. Another indication that absolutely is 100% sure that you have an AVD is when you have done your phacoemulsification and you see some fragments of the lens in that area. Normally it shouldn't be there. It can only be explained when you have no attachment of the anterior hyaloid, because the anterior hyaloid prevents the passing of those fragments to the retrolenticular space, unless you have an AVD, a total AVD, including the hyaloidal connection with the hyaloidal zonules. So that is absolutely sure. AVD is 100% there. And then another one, those who do routinely perform, look how you have a spaghetti-like distribution of your OVD. And that is because you have such a space, you can almost inject a whole syringe of your OVD in that space. So these are all things that are absolutely nice to learn and to know. Now you have sometimes in patients who have a pigment dispersion syndrome, you sometimes see a like of moon-shaped rim of pigmented deposits. This is a patient with deposits, pigment dispersion deposits, and AVD. The anterior hyaloid is very far in the posterior segment, and the pigment, of course, is attached to that. Middendorf described it as being at the posterior capsule. He was wrong. It is at the anterior hyaloid that the Middendorf is dot. Middendorf is a remnant of the cloacae canal. So this was my message. I think that you can recognize, hopefully, when you look carefully during surgery, if you have a floppy capsule, if you have pigment dispersion that you see, if you have whatever, then you have, if you have lens fragments behind your lens, you have a posterior capsule, you have an AVD. Thank you very much for your invitation.
Thank you, ma'am. Thank you.
Thank you.
Can I just add one point as a retinal surgeon? Yeah. So I had last week a patient whom I did a retinal surgery, and we inject gas into the vitreous. So unfortunately, the gas went into the Berger space.
Oh yes, it can happen.
And then that was trapped between the lens.
Yes.
And that was like a nightmare case. So over the time, that C3F had expanded, and then it ripped off the full vitreous base, and I had a giant retinal tear.
Oh.
So just wanted to share with you, like, you know, that space is actually there, and it's very dangerous, at least. So if you're injecting, if you don't inject straightly into the mid-vitreous, the gel, and you tend to inject in this space, you can have, you know, catastrophes which can happen.
Yes, but it's interesting that you explain this. This is on. So it is interesting what you say, because I was always wondering, is it better for the eye to have an AVD or not to have an AVD? Does an AVD influence also retinal tears or whatever? I'm not sure. Yeah. I don't know. But it is interesting, your case, because in fact you had a giant tear.
Giant tear, yeah.
Okay. So I think that might be
yes.
increasing the risk of, and not only PVD is important. So you have also to look at AVD.
Thank you very much.
Thank you. I have to go. Sorry for that.
Please.